How do I go back? Cannot go back. Yeah, okay. So just for those of you who are not very familiar with how we classify, generally we're talking about a randomized, this is not root canal treatment. A randomized controlled trial, a systematic review, generally as a level 1 evidence. A non-randomized study, observational studies is 2. Those case series, as in like, if let's say I do 100 cases and I just document them, I publish them, that's a case series. Is sorry for the typo, it's survey, not survey. And published expert opinion, meaning that if someone very prominent in that area write a commentary and it gets published, that's just an expert opinion. As a level 4 evidence. And then we grade for the level 1 and 2 evidence, we further grade them as either plus or plus or minus, right? And when combined with the 1 plus would indicate an RCT, for 1 plus would combine an RCT with a low risk of bias, right? So if 1 is an RCT and we think that a high quality, right, we put a plus there, it has a low risk of bias. Okay, so based on the evidence, we grade the recommendation. So if the evidence that's available is at 1 plus plus, then we can give it a A grade recommendation. So you look at the handout that you have, every recommendation is graded. So if you read a grade A recommendation, it means that when we make this recommendation, it's very well supported by high quality scientific research, and you can, it's highly reliable statement. And then it goes down to B, and then to C, and then to D. So D, we basically anything that is level 3 or 4. Why? Because level 3, if you remember earlier on, I said any one of us can just do a case series. We document our cases and we come up with a report on the series and some report on some statistics. It is a little bit of, it's still very much an expert opinion kind of thing. It's just based on my practice. There's no control, there's no randomization, and there's a high suspicion for bias. So these are just level 4 evidence, level 3 and 4 evidence, and it's a D grade. So if afterwards in the tea break, if you corner one of the work group members and you ask them, hey, you know, this thing, how do you do it? And he tells you something. Now that's at best a D grade recommendation, and you can choose to follow or not to follow. Okay, and then there are some that's really got not much evidence. Sorry, that's not even a D grade. That's a good practice point, but that's a pure expert opinion. It's not published. Okay, it's just widely accepted expert opinion. Sometimes it's just clinical common sense. Like I said, you need a parachute to jump off a plane, otherwise you'll die. Okay, it's not simply group expert opinion, but in a big enough a group of expert, and it is something which we feel that it's not important enough for us to go through the process of even in the future to when more evidence is available to come up with a statement on that, right? So it's something which is unlikely to be evaluated in future trials. So at this point, I'd like to thank the people who made this possible. The work group members, we are clinicians. We come together, we agree on something, we do the work. But a lot of the very tough, laborious work is actually done by Dr. Priest's unit. And they really have a hard time because they chase us. And as a chair, I get CC every single copy of the reminders. And sometimes to get just one response, they have to keep reminding 3-4 times. And it's not, I mean, as a fellow clinician, I can empathize with my work group members because we're busy with patients every day, and then the kind of questions that's asked is like, can you relook at this paper? Is it really this level of evidence? So it's something very dry and not something we do for a living or for fun. Yeah. So the person in Dr. Priest's unit that's doing a lot of this work is Eunzong. Is Eunzong around? Outside. Okay. Right. So he has a hard time. And special thanks also to Dr. Edwin Chan helping us with the the methodology. So he ran a workshop and teaching us how to appraise literature, how to grade recommendations, etc. Special thanks to the entire branch, Dr. Priest unit, and to the secretariat in AMS as well. Ira, is Ira around? Ira is the other person that's having a very tough time. So if Zhong stands out, remind us, and we don't respond, then he sent it to Ira and get Ira to chase us as well. So there's a lot of these chasing around for the last 3 years to come up with this set of guidelines. All right, with that, I'll bring on the first topic on today's agenda is narrow diameter implant, and we have none other than Dr. Myra Elliott, a highly respected oral maxillofacial surgeon, to share with us our findings on this topic of narrow diameter implants. So, Myra.